So in the next 20 minutes, I will talk about radiological diagnosis of liver carcinoma. I will focus on cirrhosis. So lesions like focal nodular hyperplasia or adenoma in the non-cirrhotic liver are quite easily differentiated with MRI due to the advent of tissue-specific contrast. In the cirrhosis, we have a different differential diagnosis. We see a lot less metastasis, but we have, of course, to differentiate the malignant cirrhotic nodules from the non-malignant cirrhotic nodules. In the past, the FNH-like lesion was a problem. It is not a problem anymore for the simple reason that it is excreting the hepatobiliary phase contrast. So we have improved abilities to differentiate that from hepatocellular carcinoma. Of course, arterioportal shunts are easily differentiated because of their morphology. But still, these are the lesions to avoid false positive sin. But these are not lesions that we are likely to biopsy. In hepatocellular carcinoma, often the question is, can we reach the lesion and is it not too dangerous for the patient? Because of course, these are a lot of patients with comorbidity, cirrhosis. So it's not always that easy to take the decision. That's a multidisciplinary decision. What is true indeed when immunotherapy is used and in very advanced HCC that is treated with systemic treatment, by definition now we will perform a biopsy. So the other lesions, important lesions that we became aware of due to the work mostly of pathologists, is that the presence of cholangiocarcinoma, like in cirrhosis and hemochromatosis, primary sclerosing cholangitis, the mixed tumors, like in viral hepatitis and hemochromatosis, pose challenges to the radiologist. For most, because transplantation in these patients is questionable. So let's first go to hepatocellular cancer and what do we have as radiologists to tackle the problems. I will move on from this. It's moving now, eh?
Yeah.
Okay, so in MRI we had our morphology, metabolites and vascularity. How do we make the diagnosis of a dysplastic nodule? Because mostly it is T1 hyperintense because of the increased glycogen content. So these are ways by depicting metabolites that we diagnose like dysplastic nodules. Regenerative nodules are often containing iron and will be dark on T2 weighted imaging. So these conventional sequences remain very important. And of course, due to the typical alterations in vascularity, we use three-phase contrast MRI or three-phase contrast CT. But there were more developments. The cellularity, as Tanya already showed, with the hepatocellular cancer, you will have an increased vascularity, you will have an increased cellularity, even earlier an increased cellularity than you have vascular changes. And we developed diffusion-weighted MRI to help to depict malignant tumors. I will come back to that later, but as you can see, it is like somewhat an inverted PET-like image. And the hepatocellular cancer, this is a confluent or infiltrative disease, is hyperintense. And also here, a small hepatocellular cancer is visible as compared to the surrounding cirrhotic liver parenchyma. Another contrast agent that meant a huge advantage, there are currently two of these contrast agents available, is the hepatobiliary phase contrast agents. And we actually call this delayed imaging because they are scanned during the hepatobiliary phase, the phase of the hepatic and biliary excretion of the contrast. As you can see in this example, actually, you can already see the contrast in the large bile ducts, and that is because that the contrast is excreted. The normal or cirrhotic liver parenchyma will excrete the contrast. That is what bile does, but the hepatocellular carcinoma has lost this ability to excrete contrast into the bile ducts and will become hypo-intense on this delayed image. We have two types of contrast. In one contrast, you can do this delayed imaging after 20 minutes. In Belgium, that is not allowed, this contrast. We have another type of contrast, gadolinium bobta, and you have to scan the patient 1 hour after contrast injection. And then, of course, I will not talk that much about metabolism. PET-CT in hepatocellular carcinoma for tumor detection, it is not the optimal way to image, but there is research going on if it has additional prognostic value, for instance, in selection of patients with transplantation or outside Milan criteria. So we prefer MRI over CT, that's quite clear, just because of the higher sensitivity and specificity, and especially for lesions smaller than 2 centimeters. And the last year, since I was a resident, became a fellow and staff member, there was an increasing race to detect as small as possible. It is impossible. It is, of course, important for the survival of the patient. The earlier we detect the hepatocellular carcinoma, the better the survival is. But of course, treating physicians and surgeons need to be able to find the lesions. So dynamic contrast enhanced MRI remains the cornerstone of the diagnosis. It is clear why it is. An hepatocellular carcinoma will arterialize, if I can put it that way, and will lose its portal vascularization. So it's a typical, hypervascular tumor with arterial enhancement in ideal circumstances and with washout in ideal circumstances. So here we have an arterial and a venous phase in a regenerative nodule. You won't see anything in a low-grade dysplastic nodule. So here we would put the non-enhanced T1, and we could see that that lesion is already hyperintense. What we do in these cases, we make a subtraction image of the arterial and venous phase, and we look if there is indeed increased enhancement on the subtraction image or not. If there is no increased enhancement on the subtraction, then we make the conclusion of a low-grade dysplastic nodule. A high-grade dysplastic nodule, as you can see, also this lesion would be here at the unenhanced T1 already hyperintense, but there is a clear sign of washout. So the lesion is losing its arterial enhancement and is becoming iso-intense to the surrounding parenchyma. We don't really make the diagnosis of an early HCC. I don't think that is a radiological diagnosis. We see it as an HCC. This was then the resulting pathological diagnosis, but here we have already the clear characteristics of an hepatocellular cancer, arterial enhancement, and washout. You can see the faint hypointensity compared to the surrounding liver parenchyma. And this is a straightforward hepatocellular cancer, arterial enhancement, a capsula, and really very clear washout. Why did we use, or do we use additional techniques? Well, as you can see here in data published before 2012 and 2012 or later, we didn't progress with three-phase contrast MRI anymore, and especially in hepatocellular cancer smaller than 2 centimeters. And that is an issue even, for instance, for patients referred for surgery, but also total staging for transplantation. So we had to do better. And one of these things is, although it's a bit difficult technique to use in cirrhosis, is the use of diffusion-weighted imaging. It is a complementary technique to the conventional and contrast-enhanced techniques, and it doesn't need actually contrast to visualize the tumor. What it does, and you can see that here, what we follow with diffusion-weighted MRI is the random motion of water molecules. This is one water molecule, the pattern of it, the random pattern of movement depicted between all kinds of water molecules. And the movement or Brownian movement of the water molecules will be different in water, in a good soup, a borscht, a very thick soup from Poland, or in this baked liver, there will be a lot of restriction of the water. So what is this? This is just a sequence of 2.5 minutes within your total MRI protocol. This is the technical readout. What we do with diffusion-weighted imaging, we apply 2 extra gradients that other sequences don't have. These are the sequences that measure the water mobility, just like a photo, like you take a picture. The first one takes a snapshot at time 0, and the second one takes a snapshot at time, for instance, 1 second. And in this period of 1 second, all the Brownian water, all the movement of water, every water molecule, its proton MRI will have moved randomly around. So when you look, this is an example with pancreatic cancer and pancreatic inflammation. Inflammation, there are not a lot of cells, not a lot of blood vessels, and it's in this green. What you see is that the water has really a lot of space to move around. Actually, they moved around so far that the magnetic field of the MRI during the readout cannot depict it anymore. It doesn't find these water molecules back. The image becomes black. And in the tumor, you have a lot of cells. You can see that the water molecules here are unhappy. They have red faces because they are blocked. They are bouncing on the boundaries of vascular structures and on the boundaries of cells. They remain in the field of view of the readout magnetic field. They didn't move a lot, and the tumor becomes visible as a hyperintense lesion. And this is how we use the same principle in hepatocellular cancer. When we look at this case, this is in a viral hepatitis. It's a dysplastic nodule, but as you already can see nicely on the T1, and this is what I train to my students, look first at all conventional features. And it's what already was depicted by the previous colleagues, pathologists. This is a nodule in nodule. You have a very small dark dot within the dysplastic nodule. And this is indicative for a well-differentiated hepatocellular cancer. And this is what the diffusion-weighted MRI is showing. Actually, the dysplastic nodule is nicely dark, but corresponding to the T1 hypointense spot, the tumor is becoming white. So there is a small cancer developing within the dysplastic nodule. How do we cope with this in our center? Well, the surgeons will go for a laparoscopic radiofrequency ablation, but for our quality control, during the radiofrequency ablation, they always take a biopsy. And I think that's a good way to go. MRI is a very powerful tool in HCC, but we need a constant quality control. What is the advantage of the diffusion-weighted MRI? As you can see, when combined with the contrast MRI, it increases sensitivity and specificity, and really, very importantly, for hepatocellular cancer smaller than 2 centimeters. This is not only for detection of hepatocellular cancer. This was a patient planned for a laparoscopic radiofrequency ablation. I think it is not difficult to see the small hepatocellular cancer here in the right lobe, posterior side, segment 5. But when we did the MRI, we noticed a second lesion in the left lobe, which was only visible on diffusion-weighted MRI. Well, in this patient, during the surgery, they also ablated this lesion, took the biopsy, and it was also confirmed to be a hepatocellular cancer. So diffusion-weighted imaging is also of additional value as a staging tool. The same goes for this patient, was brought in based on a CT with a single location of a hepatocellular cancer. He was scheduled for transplantation. But as you can see, the T2 is already very strange micronodular pattern. It can happen. It's not specific, but it's something that should raise a red flag. Contrast enhanced MRI didn't show an arterial enhancement, but there were diffuse hypoenhancing nodules. Well, you can also see that with diffuse regenerative nodules, so it's not that specific, should raise a red flag. But when you look at the diffusion-weighted imaging, this is not normal cirrhotic tissue. You have a diffuse granular hyperintense pattern compatible with diffuse hepatocellular cancer. Of course, we don't compromise the chances of this patient just like that. And the question was, how shall we do the biopsy? In this case, my chief of department said, it's simple, just do a blind biopsy because you say it's diffuse HCC. We did that. We did the blind biopsy in segment 6 and it was full with cancer. So it was confirmed as a diffuse HCC. The other strong tool for characterizing cirrhotic nodules is, as I already mentioned, hepatobiliary phase imaging. It takes advantage of the ability of the liver to excrete bile. So these are the two types: hydroxetate disodium, 20 minutes post-injection, and the one we can use in Belgium, hadobinat dimeglumin, at least 60 minutes post-injections. We never have patients complaining about that. If we explain it very well that it's necessary, they cope with that prolonged imaging time. Of course, within this hour, they are taken off the MRI machine, we scan another patient, and then these patients are put back for another, for the last scan. What is the advantage? Also, it increases sensitivity for detecting hepatocellular cancer. And as you can see, it is quite easy. Again, regenerative nodule, you don't see anything. The low-grade dysplastic nodule can be hyper-enhancing or shows nothing. But as soon as we have a high-grade dysplastic nodule, look at this, the hepatocellular cancer, and a bit more difficult, this is an infiltrative hepatocellular cancer. Then it becomes really easy to detect the tumor because it becomes hypointense compared to the liver parenchyma that is excreting the contrast. So we know that the combination of diffusion and hepatobiliary phase imaging contributes the most. So we will never use this alone. It's a multi-sequence examination, conventional imaging, 3-phase imaging, diffusion-weighted imaging, and then the hepatobiliary phase. And you can see here the complementary value. This is a patient with a well-differentiated hepatocellular cancer, bright on the diffusion-weighted imaging, but not visible on this delayed phase. Why? And I think I should ask this the pathologist, if they can confirm, but the well-differentiated hepatocellular cancer can still maintain somewhat hepatobiliary excretion function. So it can be a false negative on this delayed imaging. On the contrary, here, it is easy to depict the hepatocellular cancer, much more difficult on the diffusion. Why? Because the background of the liver is diseased, and all this fibrosis will also develop barriers for diffusion-weighted MRI and decrease the lesion contrast. So therefore, we have to use both in combination, and then we really get very high sensitivity and specificity. And for this, I must say that still the gold standard should be transplantation or whole tumor resection studies to confirm the accuracy of your contrast. In a nutshell, we have here a patient with a large lesion in the left lobe. It's T2 hypointense, it is T1 hyperintense. It's difficult to say. So look at the arterial phase. This is a big arterial enhancing lesion with an apparent washout, but the diffusion weighted image actually only shows a small nodule that is hyperintense, and the delayed phase image is the copy of the diffusion weighted imaging. So what was done in these patients, the surgeons have performed a radiofrequency ablation under laparoscopic guidance, ablated this lesion and confirmed it as a hepatocellular cancer. We have asked for a perioperative biopsy of this lesion, and this was a dysplastic lesion. Of course, it's possible that there is tissue sampling, but until now, this is already 2 years follow-up. This lesion remains stable in the patient. And we are progressing with the classification, standardization, and classification and reporting. I must say I'm not an absolute fan of it. It's still, it is good, but we have probably shifted a little bit too much to specificity and lost a little bit of sensitivity with it. So I think it still needs some balancing, but at least really it's a very good tool to use for. And there's where we come to the important relation to this topic, the HCC versus the LIRADS non-hepatocellular cancer. When your tumor does not really look like a hepatocellular cancer on your MRI, what should we do? There is a paradigm shift in classification, and we are radiologists that are really aware of that. For primary liver cancers, we are going away from the location of the tumor in the liver, but rather to its histological and molecular properties. So of course we don't see that. We collaborate with pathologists to find solutions and to find surrogate markers on the MRI for these cholangiocarcinomas, but especially mixed tumors and keratin 19 positive hepatocellular cancer. So when I start, the least difficult one is intrahepatic cholangiocarcinoma because it has quite specific patterns. This is the mucinous type cholangiocarcinoma. As you can see, it is more perihilar to peripheral location, of the tumor. It is rather hyperintense on T2. It is not that much apparent on diffusion-weighted imaging, but that is because of the mucinous content. But look at the typical enhancement pattern. We have a peripheral enhancement, and then very slowly, the contrast will diffuse to the center of the tumor. And this is the typical image of a cholangiocarcinoma, diffusion of the contrast into the fibrous stroma that is in the center. But then through the work of the group of Tanja Roskams, I became really aware of mixed tube tumors. And actually in this hepatology paper, we had an MRI sub-study that was published with these histological results. And we could correlate the MRI findings in mixed hepatocellular cholangiocarcinoma with the pathology. And actually what we found when we compared the mixed tumors or cholangiolocarcinomas as opposed to intrahepatic mucinous cholangiocarcinoma, that there was a heterogeneity in the mixed tumors, heterogeneous intensity at T2, but more importantly, during the dynamic contrast in MRI, we had a target-to-it-like appearance or a nodular-like appearance that seemed to combine the features of hepatocellular cancer and cholangiocarcinoma. So look in this, what we see in the mixed type tumors is a kind of peripheral washout and a peripheral very root enhancement. I will explain later how we come to this imaging pattern, but it's actually what we call an arterial venous phase mirroring. It can be linear, enhancement washout linear, or it can be nodular arterial enhancement and washout. How can this be explained? Well, this is a typical case of a mixed tumor. First of all, T2 is not what we would expect from a hepatocellular cancer. But look at this. We have a really very aggressive looking arterial heterogeneous enhancement, but the clue comes in the venous phase. We have this small hypointense border around the tumor, which is corresponding to the hepatocellular cancer part of this tumor. And in the center, in the cholangiocarcinoma part, where we have a lot of abundant fibrous stroma, the tumor is the contrast is showing its typical cholangiocarcinoma behavior. It's showing passive diffusion into the cholangiocarcinoma component. This is a nodular pattern. So on diffusion-weighted imaging, you see a dark tumor, but all of a sudden there's that dot within the tumor. It is showing arterial enhancement, but still difficult to see. But look in the venous phase, it is showing an area of washout. So this is not a cholangiocarcinoma. This is a mixed tumor with a dot of hepatocellular cancer within the cholangiocarcinoma part. And how does this go to clinics? This is a man of 55 years old. His brother died of hepatocellular cancer. He was worried. He was not sick, but he was worried. And he had hepatitis B, so he was screened with an MRI just to be sure. And we fall on this lesion. So everything had to go too fast. People were talking about immediate transplantation and so on. But look at this MRI pattern. Diffusion, not so clear, but there is an impression of a rim-like structure. This arterial enhancement is very suspicious for a mixed tumor, and look at the hepatobiliary phase imaging, the hepatocellular part is becoming visible as a non-enhancing part. And in the center, we have the passive diffusion of the tumor. So the typical image of a mixed tumor, which was proven after surgical resection. How should we incorporate in this in clinic? We don't know really well, but there was this very interesting study from the group of Valérie Vulgrin in collaboration with Valérie Paradis. So they looked for 4 imaging patterns: the type 1, the typical cholangiocarcinoma pattern; the type 2, the typical hepatocellular carcinoma pattern; the type 3, the mixed pattern. And that's a bit in the same way as what we saw in Leuven. And then type 4, a typical pattern. What would that mean? If you see an atypical pattern, it looks like hepatocellular cancer, but it's causing capsular retraction or biliary dilatation. This is not really what we see in HCC. And as you can see, we have, it's quite not so good. 48% sensitivity when looking at this pattern and 100% specificity. So we will combine, when we see this aberrant pattern, we will combine this for sure with pathology to gain more certainty. And to conclude, is life easy? No, because there was this study in the past that it didn't gain much attention, but it's the hepatocellular cancer with progenitor markers, cell markers. They look a bit like a mixed tumor, but they are hepatocellular cancers. And we don't know yet if this is a direct feature related to the K19 positivity or an expression of enhanced aggressivity, microvascular invasion in the periphery of the tumor. We have to take this into account because likely it will correlate with survival of the patient. It's interesting to correlate this with surgery. And I just have shown some examples here that the hepatocellular cancers with venous rim enhancement have a very poor survival in our case series. So that's for sure something to investigate and collaborate with the pathologists on, and for sure to see, do we have a surrogate marker for K19 positivity in hepatocellular cancers? It does make the differentiation with mixed tumors a little bit more difficult, but it is a new potential sign. And just to conclude, this is a hepatocellular K19 negative typical pattern, just one lesion, arterial enhancement washout. This is a mixed tumor, which shows then as I already showed, the nodular washout within the lesion. And this is a K19 positive hepatocellular cancer. It doesn't show in venous phase, and that's an important differential. It doesn't show washout. It shows persistent rim-like enhancement. So to conclude, MRI is the most accurate modality for detection and characterization of primary liver cancers. We have to take into account a number of distinctive features that indicate cholangiocarcinoma or mixed tumors. So it contains actually the properties of both tumors, and the target to its sign or heterogeneous nodular signs are very important. When we have an atypical imaging pattern, I think this is where biopsy is most appropriate, and look for a possible overlap pattern in K19 HCC, but at the same time, this diagnostic problem may become a diagnostic weapon to select patients for treatment. I thank you for your attention.
Thank you very much, Vincent, for this amazing overview that you could put together in somewhat less than half an hour. So it's really very amazing. So yeah, as you already mentioned, we work together in a team as pathologists, radiologists, surgeons, and that you see that gives very nice results in research and in results. Is there any question from the floor? Or but so yeah, I was impressed indeed because it becomes very difficult now also for you, I suppose, if you have the mixed patterns and then the K19, because it's of course all, let's say, it all flows together. It's a spectrum. So we try to categorize them in groups, but it remains a spectrum. So, but at least it's, I think, very important to recognize the mixed patterns from the moment that they have some biliary features. Yeah, it's a bad prognosis or a worse prognosis.
I think it's the strange thing is that, yeah, for now, the K19 feature, we need to validate if it's really true, but I don't really have the impression treating clinicians know what to do with it or what they should do. But even the discussions on the transplantation board when we suspect a mixed tumor, it's often quite emotional, like, oh, we should do, it's the only chance, and you have pro and contra. And I think it's clear it's easy. If you have a mixed pattern on MRI, you biopsy. If you don't have it, then normally we don't in a curable patient. But if you have that mixed pattern, you should confirm. It's quite straightforward. Yeah.
Okay. Thank
May
you.
I ask one question?
Yes.
Sure.
Hi, this is Jiangzhu from Mount Sinai as well. Thank you for all those great lectures. So I have a general question. So for those CK19 positive HCCs, is there any studies for CK7 on those cells? Do we show like a weak staining pattern as a metaplastic hepatocytes, or they show similar strong staining? And the second question is, apart from CK19, is there any other markers we can use for like maybe more progenitor features? Thank you very much.
Yeah, so keratin 7 is, as you mentioned, it's a less specific marker for progenitor cells. It also stains rosettes in cholestatic rosettes, for example. So hepatocytes that transform a little bit into the biliary direction to protect themselves from the intoxication by bile salts. So, but these are still hepatocytes. They still have a canaliculus, and they just get some features of cholangiocytes to protect themselves. So you should be more stringent in your marker, and that's why keratin 19 is better, because many hepatocellular carcinomas will show rosettes which are keratin 7 positive, and then you would make the diagnosis of biliary features too often, because it's a classical feature in hepatocellular carcinoma that there can be some rosette formation. I don't know whether Swan Tung has another remark to make in this sense.
No, we do the K19, because it correlates with more aggressive tumor and progenitor cell feature, but we don't do CK7.
No, indeed, because it will only show the rosettes, which are still hepatocytes. They're just forming a rosette. With bilirubin, usually with bilirubin in the center of the rosette. Okay. More other markers of progenitor cell. Yeah, there are other markers that show very similar results, but I think the K19 is the most, let's say, the best studied and the most representative. In many centers, it's already confirmed that it indeed stains a subtype of classical HCCs. But if you don't do the stain, you would just miss them. And then, they're more aggressive than the negative ones. So it's still important to recognize a subtype, I think. Okay, I think then we have to proceed. You want to have another question, Julian?
Just a short question to Vincent. He mentioned repeatedly radiofrequency ablation. So when do you discuss to do chemoembolization?
Multifocal disease, for sure, when radiofrequency ablation is not possible anymore, or biologically useless. If you have more than 3 lesions, I think that will become difficult. Size of the tumor, if you have a tumor larger than 3 centimeters, a radiofrequency ablation or microwave ablation will not be efficient anymore. So these are a number of
Okay.
diagnostic signs where you cannot do it.
Good, thank you.